As we start to look at the cardiovascular system, we're first going to focus on the heart. The objectives for this section are be able to describe the function of the cardiovascular system, describe the anatomy and location of the heart, list the functions of the structures of the heart, describe the pulmonary and systemic circuits and tell their general function, list the parts of the intrinsic conduction system and tell the function of each, be able to label a 3-lead EKG and describe what each wave represents, describe the events of the cardiac cycle, trace blood flow through the heart, describe the factors that determine cardiac output and stroke volume, and describe the homeostatic imbalances of the heart. The cardiovascular system is composed of the heart and the blood vessels. The purpose of the cardiovascular system is to transport materials throughout the body. The structure of the blood vessel allows for exchange of the materials between the blood and the body fluids so that nutrients can get to the cells, waste products can be carried away from the cells, oxygen can get to the cells, carbon dioxide can be carried away. The heart weighs about 250 to 300 grams. It's roughly the size of your fist. It's located in the middle of the thoracic cavity in the mediastinum. It rests on top of the diaphragm, which is the muscle that separates the thoracic and abdominal cavities. It's not centrally located. It's a little more to the left. About 2/3 of the heart lies to the left of the midline. The base points toward the right shoulder, and the pointy part, the apex, points to the left hip. So here you see right down the middle, you can see how the heart is mostly on the left side of the body. This would be the base, this would be the apex. Here's the diaphragm, and that side of the heart lays almost directly on top of the diaphragm. It's actually loosely connected to it with some connective tissue. This point right here, that's labeled the point of maximal intensity, if you put the stethoscope right here, sort of at the tip of the heart, this is where you will hear the heart sounds most clearly. Now to show you a transverse section, there's the heart, pretty much centrally located, the lungs on either side of it. Here's the sternum and here's the vertebra. So the heart is located between two hard surfaces, which is why CPR works. When we push on the sternum, it will collapse the heart. When we let off, it will let the heart open back up. The heart is covered first by an epicardium. This is a visceral layer of the pericardium. Then there's the myocardium. The myocardium is the muscle layer. It's held together by a lot of connective tissue, and you'll remember that the muscle of the heart is a special muscle, the cardiac muscle. There is a fair amount of connective tissue associated with these muscle cells. Then the entire inside of the heart is lined with the endocardium. This is a smooth, single layer of epithelial cells which is designed to reduce friction in the circulatory system. The heart is enclosed by a fibrous sac called the pericardium. It's one of the serous membranes, and you'll remember that serous membranes are pushed up against the walls and then come back and cover the structure within. So here's your heart doing that. The outer sac, the fibrous pericardium, is not stretchy, but it's loosely covering the heart. And then the serous pericardium lines the fibrous pericardium, that will be the parietal layer, folds back and covers the heart, and that's the visceral layer. And the visceral layer is the same as the epicardium. There's a little space between the two layers of the serous pericardium, and this will be filled, or will have a little bit of pericardial fluid in it. It won't really be filled with fluid. The fluid acts as a lubricant, so as the heart increases and decreases in size as it beats, it moves without much friction against the walls of the pericardium. Here's another picture. This is one of the blood vessels associated to the heart. So you see how the fibrous pericardium, then here would be the parietal serous pericardium, the visceral serous pericardium, or the epicardium, same thing, with the space where some pericardial fluid would be, the myocardium, or the muscle layer, and then the single layer of epithelial cells that make up the endocardium. Then you would have one of the heart chambers, one of the hollow spaces in the heart here. The pericardium can become inflamed. It can become damaged. Sometimes a virus infects it. Sometimes it becomes damaged as a result of pneumonia, and bacteria from the pneumonia get over and infect the pericardium. When you have pericarditis, the fluid in the pericardial space here, the pericardial fluid, gets thick so the heart doesn't move as freely against the pericardial sac, and sometimes may increase in volume quite a bit. And if that happens because the outer fibrous pericardium isn't stretchy, if you get too much fluid here inside the pericardial space, you will actually compress the heart and it won't be able to beat. The heart has 4 chambers. The right and left upper chambers are the atria. These are the receiving chambers. When blood returns to the heart, it enters one of the 2 atria. Then the lower chambers are the right and left ventricles, and these are the discharging chambers. These are the chambers that will force blood from the heart into the blood vessels. So there's the right atrium and the left atrium, and the right ventricle and the left ventricle. The heart has also 4 major blood vessels attached to it. Attached to the right atrium are the vena cavae. There's an inferior and a superior vena cava that come and merge right in the back of the right atrium. The left atrium has the pulmonary veins coming into it. There are actually 4 pulmonary veins, but once again they merge just right behind the left atrium. The right ventricle has the pulmonary trunk attached to it. The pulmonary trunk is an artery. And the left ventricle has the aorta attached to it, and the aorta is the largest artery in the body. So that the superior and the inferior vena cava are both coming into the right atrium. The pulmonary trunk comes out of the right ventricle, comes up and it branches into the right and left pulmonary arteries. The pulmonary veins are these 4 vessels that come back and they come into the left atrium here. And then the aorta comes off of the left ventricle. It goes right behind the pulmonary trunk and comes out here. The heart acts as a double pump, but both of the pumps act in unison. They pump at exactly the same time. Unoxygenated blood is going to return to the heart through the venous system. The right side of the heart will then pump the blood to the lungs because this unoxygenated blood comes back to the right atrium. The oxygenated blood will then return to the left side of the heart through the pulmonary veins, and the left side will pump the blood to the whole body. So the right side is going to receive blood from the body. It's going to be unoxygenated blood. And when the right side pumps, it's going to pump the blood to the lungs so that we can have that gas exchange. This is called the pulmonary circuit. Pulmonary has to do with the lungs. This oxygenated blood returns back to the left side of the heart. So when the left side of the heart receives this oxygenated blood and it beats, it's going to force the blood out into the arteries that go to all the parts of the body, break down to the capillary beds, and delivers oxygen to the tissues. This is called the systemic circuit. So we have the pulmonary circuit to pick up the oxygen. We have the systemic circuit to deliver the oxygen. The right side pumps to the lungs, the left side pumps to the body. And these 2 pumps are doing the same thing at exactly the same time. All right, blood leaving the right side of the heart will travel where? The brain, the lungs, the kidneys, or the digestive system. Remember, the right side pumps to the lungs. That's the pulmonary circuit. The structure of the heart that receives blood from the body would be the atrium, the ventricle, the myocardium, or the pericardium. Well, remember, the atria are the receiving chambers. In particular, it would be the right atrium that receives blood from the body. There are 4 valves inside of the heart. The atrioventricular valves, or the AV valves, are the ones that are between the atria and the ventricles. On the right side of the body, the right AV valve is also known as the tricuspid valve. And the left AV valve is known as the bicuspid valve, or the mitral valve. Now I try to remember this by the right side of the heart has the tricuspid valve. The T's go together, meaning that on the left side we must have the bicuspid valve or the mitral valve. The other two valves are the semilunar valves, and these are between the ventricles and the blood vessels attached to the ventricles. So on the right side, the pulmonary trunk is attached to the right ventricle, so that valve is called the pulmonary semilunar valve. And on the left side of the body, the aorta is attached to the left ventricle, so the aortic semilunar valve is the valve that's found there. So here would be the right atrioventricular valve or the tricuspid valve, and here would be the left one, the bicuspid or the mitral valve. Then the pulmonary semilunar valves, sort of the doorway to the pulmonary trunk, and the aortic semilunar valves are the doorway to the aorta. The purpose of the valves is to prevent backflow. In the circulatory system, we want the blood to only flow in one direction, and yet when the heart pumps, it tends to constrict and it will force blood backwards in the heart. Think about holding a ketchup packet, having both ends cut off the ketchup packet. If you squeeze it in the middle, ketchup's going to squirt in both directions. We don't want that to happen in the heart, so what we do is we have these valves, and when blood tries to go back the wrong way, it pushes the valves closed, preventing blood flow back into the atria. Same thing happens with the aorta and the pulmonary trunk. When the heart starts to relax, it would tend to suck blood back into the ventricles, and again, as blood tries to move backwards into the heart, those semilunar valves close in much the same way. Sometimes we have incompetent valves, that is, the valves don't close all the way, and you may have a little blood that seeps back between them. This will cause a murmur, something that you can hear with a stethoscope, a little gurgling or bubbling sound, and that's when we say we have a valvular insufficiency or an incompetent valve. Most people, as we get older, get a little bit of a murmur because one of the things that happens as you age is all of your elastic tissues lose some of their elasticity, and that's true of these valves. So they tend to not close as completely. This is not particularly considered pathological in an older person. They do tend to listen to it and see if it gets any worse, but a little bit of a valvular insufficiency is expected as you age. Now, that aging process where the valves lose their flexibility is called valvular stenosis. The heart is one of the organs of your body, and it has to have blood delivered to it. It needs oxygen and nutrients, and it has waste products that need to be carried away, and that's the purpose of the cardiac circulation. There are two major arteries that feed the heart. They are the right and the left coronary arteries, and they come directly off of the aorta. Just as soon as the aorta is out of the heart, these two little blood vessels peel off of it. The left coronary artery has two major branches. One is the anterior interventricular artery, sometimes called the LAD, for left anterior descending artery. The other branch is the circumflex artery. Then the right coronary artery has two major branches. They have the marginal arteries. There are one or more marginal arteries. It'll vary from person to person. And then we have the posterior interventricular artery. So as we look, here is the aorta, and here are those two blood vessels coming off, the left coronary artery and the right coronary artery. The left one branches into this circumflex artery, which wraps around to the back of the heart. And here is that anterior interventricular artery coming right down the middle between the two ventricles. On the right side, we branch into marginal arteries, and there may be more than one that branches off here. And then it wraps around to go up down the back of the heart, and that's the posterior interventricular artery. Now, it looks like all of these arteries are interconnected, and they usually are. These are called anastomoses, and what this allows for is what's called collateral circulation. The heart is very dependent upon oxygen and nutrients. We have to have a lot of ATP to keep the heart pumping. So in order to ensure that there's a good blood supply, Mother Nature built in a lot of detours for this arterial blood. if one of these arteries becomes blocked, even partially, these other tissues that it feeds can still get some blood because of this anastomosis. So we have blood flow pretty consistently throughout the heart. Now, the blood that leaves the arteries goes into the capillary beds of the heart muscle, doing their nutrient waste, oxygen, carbon dioxide exchange, and then we have to drain those tissues, and all of the myocardium is drained by the various cardiac veins. You have this middle cardiac vein and this great cardiac vein, this anterior cardiac vein, but they all tend to pool back here in the back of the heart in the coronary sinus, which returns the blood directly back into the right atrium. Angina pectoris, or angina pectoris, it's pronounced either way, occurs when there's a blockage of the coronary arteries. Now, this means that the heart muscle's not getting enough blood, and so there tends to be some chest pain. When we have a deficiency of blood to the myocardium, we initially have ischemia, which means there's just a little bit of a lack of oxygen to the heart muscle, and there's some damage to the heart muscle. The treatment for this is to take vasodilators, and people who have episodes of angina will usually keep nitroglycerin pretty handy because it's a potent vasodilator. If they do not treat their angina pectoris with a vasodilator, they may go ahead and have a myocardial infarction, or an MI. This is a heart attack. Whenever there's prolonged blockage of one of these blood vessels, lack of oxygen eventually causes the cells to die. Now you remember that cardiac muscle does not undergo regeneration. There's no repair, so it replaces with scar tissue, fibrous connective tissue. And fibrous connective tissue will not act the same way that heart muscle tissue does. So the heart loses some of its ability to pump blood with every myocardial infarction. Now some myocardial infarctions are so massive that the heart is pretty much totally killed, and these people die as a result of that myocardial infarction the first time. The heart has to beat, and it's really interesting how the heart knows when it's supposed to contract and not contract. Some of the muscle cells of the heart are autorhythmic. That is, they do not have to be told by the nervous system to contract. They sort of do it on their own. And this collection, about 1% of the heart muscle cells, make up what's called the intrinsic cardiac conduction system. One cluster of these cells is found in the back of the atrium, the right atrium, and it's called the sinoatrial node. Then sort of at that crosshairs where the atria and the ventricles all come together, we have another little cluster of these autorhythmic cells called the AV node. Some of them then travel down through the center of the heart between the walls of the two ventricles, and this is called the atrioventricular bundle, or the bundle of His. And partway down it branches into the right bundle branch and the left bundle branch. As it gets down to the apex of the heart, these fibers spread out across the ventricles of the heart, and they're called the Purkinje fibers. Now the way this works is the sinoatrial node will discharge. And because the heart muscle cells are held together by gap junctions, as soon as one cell has been told to discharge, immediately all of the other cells know that they are supposed to discharge as well. So the contraction of these few cells here trigger the contraction of all of these cells across the atria. Now there is a band of connective tissue between the atria and the ventricles, and this acts as an insulator. In other words, this message from the sinoatrial node doesn't get here to the ventricles. So we've told the atria to contract, but we haven't told the ventricles to contract yet. And we really don't want them all contracting at the same time, because that would sort of defeat the purpose of pumping the blood. We want to pump from the atria to the ventricles, then let the ventricles pump the blood out of the heart. So we need to slow down that contraction a little bit. So we tell the atria to contract, and we have a block so that they can't get through and tell the ventricles to contract just yet, but we still got to get the message to the ventricles. So this group of cells here, the atrioventricular node, is discharged by the sinoatrial node, and that triggers a discharge down the bundle of His, the right and left bundle branches, and into the Purkinje fibers. Now the Purkinje fibers then communicate with all of the muscle cells, again through gap junctions, of the ventricle, and they know to contract. Now, just like skeletal muscle, you tell it to contract, and when you're not telling it to contract, it relaxes automatically. So there's just one bing, and the atria contract, and since there's no more signal for them to contract, they relax. And then we tell the ventricles to contract one time, and then there's no more signal, so they automatically relax. The SA node is called the pacemaker of the heart. Given its own little system there, it will discharge about 75 beats per minute. When the heart is going somewhere between 70 and 80 beats per minute or so, we say that the heart is in normal sinus rhythm, indicating that the sinoatrial node is doing its job and taking care of everything. Now the other parts, the other cells of the intrinsic system can also discharge on their own, but not as frequently as the SA node. The AV node can fire about 50 times per minute, and the AV bundle and bundle branches can fire about 30 times per minute. Whenever the AV node is discharged, it has to start over again building up to discharge. Same is true of the AV bundle and the bundle branches. So whichever one discharges the fastest controls the heart rate. And normally the SA node, discharging 75 times per minute, is going to keep cleaning the signal off of these other two, so they never get a chance to discharge on their own. They're always told to discharge before they build up their own signal. Arrhythmias are what happens when you have irregular heart rhythms. Usually arrhythmias are because of some sort of defect in the intrinsic conduction system. Some part of it is not doing its job. Fibrillation is when the heart muscles are really not paying attention to much of anything. You have rapid, irregular, or out of phase contractions, and so the muscle is contracting, but it's contracting randomly and erratically. When this happens, blood is not pumping. The AV node sets the pace at about 40 to 60 beats per minute. So if the SA node is damaged or becomes fibrous, which is something that can happen with aging, then the AV node will take over. It will be the fastest thing, and it will keep the pace going between 40 to 60 beats per minute. Now, this helps maintain the circulation of blood to the body cells so that there's not damage there, but it's not a strong enough or fast enough rate for there to be much response to any kind of stress. So people sitting still, not moving, will feel okay, but as soon as they stand up or start to move very much at all, that 50 beats per minute is not going to keep blood circulating fast enough to keep blood going to their brain. Heart block is another condition where the conduction system is damaged. Remember that the SA node fires, but in order for the ventricles to know about it, the AV node has to be in position. It has to be functional. If the AV node or the AV bundle or the Purkinje fibers are damaged, the ventricles will not get the message. Now, if the AV node is what's damaged, the AV bundle and the Purkinje fibers can discharge about 30 beats per minute, but that is not fast enough to maintain circulation. And one of the things that happens when blood flows too slowly in your body is it begins to clot. So damage to the AV node or to the bundle branches can lead to what's called heart block. When this happens, typically you need a pacemaker. Tachycardia is a condition where your heart at rest is over 100 beats per minute. The faster your heart beats, the more likely you are for it to go into fibrillation. Bradycardia, on the other hand, is when at rest your heart beats slower than 60 beats per minute. This can be an indication that the SA node is not functioning and that the AV node is taking care of the pacing of the heart. However, well-trained athletes, because they will have their heart muscles so well toned, may have a heart rate less than 60 beats per minute, and it's not pathological. Because all of the signaling to the heart is based on electrical currents, we can measure those electrical currents through electrocardiography. There was a move at one time to start calling them ECGs, but I don't think that's really hung on. I think everybody pretty much still calls them EKGs. But this is simply monitoring those electrical currents that are generated and transmitted through the heart by the cardiac conduction system. Now, on a simple 3-lead EKG, you get 3 deflection waves. The size of these waves, how long they last, when they occur, are always consistent in a healthy heart. So if there are changes in the pattern, this can tell a cardiologist that there may be some heart damage or some problems with the conduction system. Now, your standard 3-wave EKG has a P wave, a QRS complex, and a T wave. They'll talk about the PQ interval and the ST segment and the QT segment. These are some things they look at and they time and they look at the size of. Now, what is happening is when the sinoatrial node tells the atria to contract, there is a little bit of a disturbance in the electrical conductivity of the heart, and we get our P wave. So this represents the atria depolarizing or contracting. As the atria relax, there's another little tiny disturbance that we get another little wave right here, but because the ventricles start to contract at the same time, we kind of cover up that wave. So this QRS complex is what happens when the ventricles are contracting. Then the ventricles relax, and we see that little change in electrical conductivity as the ventricles relax. So this PQ interval represents how long the atria are contracting, and the QT interval represents how long the ventricles are contracting, their contraction and relaxation. And this ST segment then would be the space between ventricular contraction and ventricular relaxation. And different drugs, different ion imbalances will change the way some of these look. So being able to read one of these helps cardiologists determine what may be wrong with the heart. Now, here you see a normal sinus rhythm. And you can figure out how many beats there are per minute. There's about 70 beats per minute on this one, about 75 beats per minute on this one. And you see the PQRST, PQRST. And these little blocks you see all help with determining timing. Now this one looks a little different. You definitely see the QRS, and this must be the T, and then there's nothing. And then there's a QRS, and then there's a T. So this one has no P waves. This would indicate that the SA node is not doing its thing. In other words, the atria are not contracting. They're not getting a signal to contract. Also notice that the space between these spikes here is much bigger. So this is a slower heart rate. That would be consistent with the AV node being the pacemaker. All right, this one has got a PQRST, P, PQRST, P. Looks like we're missing some ventricular contractions in here. This is the kind of pattern you would see when you've got a heart block. In this case, it's a second-degree heart block, because the SA node is firing like it's supposed to. You're getting regular P waves all across here. But somehow that signal is not getting through to the ventricles. So it's sort of like the bundle branches or the Purkinje fibers are taking care of telling the ventricles when to beat. So the atria are beating more frequently than the ventricles. And this just looks like a mess, okay? And this is what fibrillation looks like. This is VFib, this chaotic EKG pattern. And of course, when this is going on, even though the heart muscle is wiggling and beating, blood is not pumping anywhere in the body. So this is not an effective heartbeat. Sometimes you see the flat line, and you'll see them start to shock the patient. And by the way, the reason they shock the patient is sort of to clear the signal up and see if the heart won't start pacing regularly. Back in the days of old circuit board TVs, if the picture went a little haywire, it was not uncommon to see somebody go over and hit the side of the TV. The reason being is it would clear the circuit boards and let them start working again. And shocking the heart does a similar thing. You basically stop it and then hope that it spontaneously goes back to the right rhythm. When you have a totally flat line, that means nothing's working. There's no electricity in the heart. And most of the time when they shock flatline people, they do not come back. The only problem with flatlines is sometimes because of the instrumentation, you may have tiny, tiny little wiggles. If that's going on, you have a chance of defibrillating them and getting them to come back. But if they're flatlined, the cardiac conduction system is not going to respond. All right, a cardiac cycle is one heartbeat. Now, when we use the term systole, we mean the contraction of the muscle, and diastole would be the relaxation of the muscle. So one complete heartbeat could be described as atrial systole, atrial diastole, ventricular systole, ventricular diastole. In other words, the atria contracts and relaxes, the ventricle contracts and relaxes. Now, usually when we use systole and diastole, we're talking about ventricular activity, but it does apply to both. So when we look at the cardiac cycle, what we have going on first is blood returns back to the heart. The entire heart is relaxed, and so blood returns back through the vena cava and the pulmonary veins, fill the atria, and because the heart is relaxed, the AV valves are open, so blood just kind of passively flows into the ventricles a little bit. And then the atria get their signal to contract, and they sort of squeeze the last little bits of blood into the ventricles. This is called the ventricular filling period of the cardiac cycle. Now, the ventricles, as soon as the atria start to relax, the ventricles begin to contract. There is this phase called the isovolumetric contraction phase, where the ventricles have contracted just enough to close the AV valves, but they haven't gotten enough pressure behind the blood to open up these semilunar valves. But as the ventricles continue to contract, they overcome the pressure in the blood vessels that are attached to the heart and push the semilunar valves open. Then the ventricles relax. So this is called ventricular systole. Once the ventricles relax, there's more pressure in the blood vessels than there is in the ventricles as the ventricles begin to relax. So when the blood tries to flow backwards against that pressure, the semilunar valves close. The ventricles again there's just enough pressure to have the AV valves closed and the semilunar valves are closed, and the ventricles continue to relax until the AV valves open and we start over with another ventricular filling period. When you listen to the heart, you hear the heart sounds, or the lub dub, and that's really what they're called. What you're hearing are the valves in the heart closing. So the first sound, the lub, is the AV valves closing as the ventricles begin contraction. And the dup is the semilunar valves closing as the ventricles begin to relax. So these sounds are all around ventricular contraction. And as we mentioned earlier, if the valves aren't doing their job, then you may also hear murmurs, or as a result of valvular insufficiency. Cardiac output is the amount of blood that is pumped by the ventricle in 1 minute. Now, each ventricle has to pump the same amount of blood, because otherwise one would get ahead or behind the other one. You can determine cardiac output if you know the heart rate and the stroke volume. Now, the stroke volume is the amount of blood that's ejected from the ventricle each time the heart beats. So each heartbeat times the amount of blood pumped would give you the cardiac output. In a normal, healthy human, about 70 milliliters of blood are pumped with each heartbeat. So that would be the stroke volume. So if we do the math, if we're in sinus rhythm at 75 beats per minute and we're injecting 70 milliliters per beat, then every minute we should pump about 5,250 milliliters of blood, or 5.25 liters. Now, you'll remember that 5 to 6 liters of blood is the total amount of blood in the body. So the heart pumps your entire blood volume about every minute. Now, if we change either of these, we will change cardiac output. But it's important that cardiac output remain fairly constant. So if one of these goes up, the other one has to go down, or vice versa. If one goes down, the other one has to go up. So what are some of the factors that influence our heart rate and our stroke volume? Let's look at stroke volume first. One of the things that influences stroke volume is something called Starling's law of the heart. Basically, the more you stretch the cardiac muscle, the greater the contraction is going to be. So if you put a lot of blood in a ventricle, it's going to pump harder to get that blood out of there. The more blood that comes back to the heart, the more stretch there is on the heart. And the blood returning to the heart is called the venous return to the heart. So anything that enhances venous return to the heart will increase your stroke volume because the heart will beat more strongly. If cardiac return or venous return to the heart is low, then the heart contraction will be weaker because it won't be stretched as much. But the more blood that returns, the harder the pump pumps. Now, if one side of the heart pumps more blood than the other side, then the venous return is going to be increased to the other side of the heart. So if you're exercising, for example, and you've got venous return coming back to the right side of the heart because of skeletal muscle activity, squeezing the veins and returning more blood to the heart, then you're going to have an increased heart rate and force, and you'll be sending more blood through the lungs to the left side of the heart, and the left side of the heart will also increase its force and rate to keep up with the right side, and you'll send more of that oxygenated blood to the muscles. So it's a pretty neat system there where you start to exercise, automatically the cardiovascular system is going to respond to that. On the other hand, if you have blood loss, what's going to happen is you're bleeding out on the pavement somewhere, and you don't have that blood coming back to the heart. So you have a reduced stroke volume because there's less stretch. This means that the heart beats less forcefully. Now, in this case, in exercise, we're going to have increased heart rate and force. Here we're going to have less force, but in order to try to keep our cardiac output up, we're going to have more heartbeats. Heart rate is the other thing that affects cardiac output, and there are several things that can affect heart rate. The biggest one is the autonomic nervous system. You'll remember that the sympathetic nervous system is your E system, your emergency system, and that one of the things that happens when you're under stress is your heart rate increases during stress. So one of the reasons that your heart rate goes up during exercise, besides the increased volume and stretch, the rate goes up because of the stress. The parasympathetic nerves will slow and steady the heart after the demand is over. And it's the vagus nerve that slows down your heart. And this one runs down the side of your neck. And sometimes if people get that pressed just right, they will slow down their heart inappropriately. Hormones and various chemicals and ions can have a factor on the heart rate. Epinephrine, which is released by the adrenal gland and the autonomic nervous system, the sympathetic system, and thyroxine, which is the metabolic hormone from the thyroid gland, both act to increase heart rate. Various ions can also affect heart rate. The heart is particularly sensitive to calcium and potassium ions. There are physical factors that influence heart rate. One, your age. The fetus has the fastest heart rate of any. Children have fast heart rates. As you get older, it tends to decrease with age. Women have faster heart rates than men normally. If you're hot, you've got a faster heart rate than if you're cold. Cold decreases your heart rate. And yes, while exercise will cause your heart rate to go up, exercise, not only does it exercise your skeletal muscles, but also your heart muscles. So someone who is very fit, has well-toned muscles, will also have a well-toned heart. So they will have a more efficient heart. So that's, remember I said one cause for bradycardia that is not pathological is someone who is a well-trained athlete. So here's various things that affect your cardiac output. If you have experienced a crisis, sympathetic nervous system activity, you've increased not only the force of the heart, but how contractile the heart is. That's going to increase your stroke volume. If you have a decreased blood volume, venous return, your stroke volume and your heart rate will change. Okay, all of these are going to have an effect on that cardiac output. Exercise will increase venous return, increasing your stroke volume. Some sort of crisis stressor activates the sympathetic nervous system, which increases your heart rate. Parasympathetic system will turn that down. High blood pressure or blood volume will also stimulate the sympathetic nervous system. Hormones increase heart rate. So there's just all kinds of things, and all of these interact. The bottom line is to keep cardiac output as constant as possible. Congestive heart failure occurs when there is a weakened myocardium. The muscle of the heart is flabby. It just doesn't have the snap it should have. As a result, it will not pump efficiently. It can't. It's just like when you don't have well-toned skeletal muscles, you can't lift as much. As a result, even though there may be all the signals to cause the heart to beat, it's just not forcing out enough blood, and so we can't maintain circulation. Some of the causes of congestive heart failure include coronary atherosclerosis. Now, if the atherosclerosis is a narrowing of the blood vessels so that there's reduced blood flow to the cardiac muscle, and the cardiac muscle is hypoxic, it doesn't get enough oxygen, so we have some of that ischemia happening. Over the course of time, all of those damaged heart muscles will begin to be less effective in their activity. Hypertension is another thing that can cause congestive heart failure. Your ventricles have to have enough force behind the blood to push open the semilunar valves of the aorta and the pulmonary trunk. If you have high blood pressure, the heart has to work harder to overcome that higher pressure in the arteries to force open the semilunar valves. Repeated myocardial infarctions will result in increasing amounts of scar tissue on the heart, and scar tissue is not productive tissue. And cardiomyopathy is just a general term saying that there's some disease of the cardiac muscle. They don't really know what causes it. Cardiomyopathy can occur in relatively young people. Sometimes they think it might be triggered by a viral infection. If the left side of the heart becomes flabby or becomes unresponsive or can't pump like it should, then blood is going to back up in the pulmonary circulation. This means that blood will not flow out of that pulmonary circuit well. Whenever blood kind of gets backed up in blood vessels, fluid tends to leave the blood into the surrounding tissue, and so these people experience pulmonary edema. Usually the first symptoms of congestive heart failure are left side failure symptoms, and pulmonary edema puts a lot of fluid around the lungs so the lungs can't expand like they should, and you'll see people sleeping in beds propped up at about 45-degree angles because this allows the fluid to go down to the bottom of the chest cavity so that they can breathe a little better. Right side failure is when blood will back up then in the systemic system. Here the edema will be out in the system, so they're always concerned about people whose ankles swell and hands swell and things like that, because that's another symptom of congestive heart failure if the right side is failing first. Now, if one side fails, the other side will not be far behind it, because the pressure you put up with congestion in the pulmonary circuit will start to damage the systemic circuit and vice versa. Which of the following would cause an increase in cardiac output? An increase in heart rate, an increase in stroke volume, an increase in blood pressure, or A and B are correct? Remember, cardiac output is heart rate times stroke volume, so these are the only two things that will affect cardiac output. The QRS complex of an EKG occurs during atrial contraction, atrial relaxation, ventricular contraction, or ventricular relaxation. That's the one that's going on during ventricular contraction. The P wave gives us atrial contraction. We don't really get a wave for atrial relaxation because it's covered up by the QRS complex. And then the T wave reflects ventricular relaxation.